Let me introduce our next speaker, Dr. David Schulz. I say that right? Schulz. He joined Wake Radiology this year after completing his residency in diagnostic radiology and fellowship in abdominal imaging at Duke. He is a native of Lansing, Michigan. Dr. Schulz earned his Bachelor of Science degree from Michigan State University and then received his medical degree from that institution's College of Human Medicine. So he knows a lot about humans, right? Okay, good. He went on to complete a year internship in internal medicine at Michigan State University, Sparrow Hospital in Lansing before coming to Duke. And between the gray skies of Michigan and the blackness of the reading room, when he's not working, he enjoys time outdoors in the sun, usually chasing down his 3 boys. So today he's going to be speaking to us about the appropriate use of CT with regard to abdominal imaging. Please welcome Dr. Schulz.
I think, is this on now? Okay, good. Okay. Can figure out technology, that's always the first step. So today I'm going to be discussing some of the indications for CT use in your practice as well as some alternative modalities. I don't think this is... there we go. So first of all, let's discuss a little bit the players, and we'll do this very briefly because I understand you've already been talked to a little bit about an introduction to CT. I won't spend too much time on this. So what is CT? Again, it uses the rotating X-ray tubes and detectors and utilizes the attenuation of the photons as they pass through the body. And then we use some complicated math to produce a grayscale map, which we see as images. And currently we use multi-detector technology, which allows for much faster image acquiring as well as better pictures. And importantly, CT may be tailored for the indication. So that means we have to have an appropriate indication, and it can help us get better images. Let's see. There we go. Went backwards.
Oh, wait, how did you figure that out?
I didn't figure it out, I don't think.
Is that the bottom trigger?
It's a bottom trigger.
Maybe we'll have you, we've had success over here.
Well,
Instead of changing footing.
I can move.
Okay.
Not a problem. There we go. Okay, we've done that. So briefly, what is MRI? One of our alternative modalities to CT. MRI is based on magnetization of atomic nuclei, uses strong magnetic fields and gradients. There's a lot of pulse sequences available, something that we as radiologists need to know about in order to tailor the study for the indication. And again, the important thing about MRI is it does not involve any radiation. So how about ultrasound? Again, so ultrasound uses transmission of targeted sound waves. The degree of the echogenicity that we perceive on images depends on the ability of our target to absorb or reflect sound waves. The unique aspect of ultrasound is that it's portable, and like our other studies, it can be tailored for the indication. And so how about PET? Well, PET uses a substrate, which is 18F-fluoro-2-deoxyglucose. And this FDG analog, as it's called, is transported into metabolically active cells and then trapped. And the whole principle of PET imaging is that, in general, tumors are highly metabolically active and therefore will have increased uptake as well as trapping of this substrate. And I'm not going to get into too much detail about PET because Dr. Haugen's going to follow me with some of the current indications for utilization of PET. But here's an example. From left to right, we have coronal CT images. In the middle, we have the attenuated corrected PET images. And on the right, we have fusion PET images. And as you can see, there's these areas of increased FDG uptake within the spleen. Now, you don't see anything on the CT images, and they're also apparent on the fusion images. So as we can see that this is recurrence of Hodgkin's disease in the spleen. And without the PET, it would have been very hard to pick this up. So to go through some of the use of CT and these alternative modalities, we're going to use this clinical indications outline. We're mainly going to focus within the abdomen because that's my area of expertise. But we're also going to talk a little bit about the chest. We as body imagers do a lot of the imaging of the chest as well. We're going to discuss adult hematuria, and then we're going to do what I call an imaging boomerang. And the reason I call it that is because it's imaging that begets other imaging because of something incidentally found. The first one is an adrenal incidentaloma. Then we're going to move on to right upper quadrant pain, then discuss a little bit of lower abdominal and pelvic pain, and then move north into the chest, discuss some CT after detection of masses and nodules, another imaging boomerang, which is the solitary pulmonary nodule, the persistent chest X-ray opacity, and then acute shortness of breath and chest pain. So adult hematuria, as you know as clinicians, it may be visible macroscopic hematuria or detected only on urine examination, which is a microscopic hematuria. Typically, gross hematuria with passage of clots suggests a lower urinary tract source. Now, the causes of it is quite widespread. Typically, we're looking at calculi, neoplasms, infection, or trauma. But there's some rarer causes like drug toxicity, coagulopathy, and varices, which sometimes come up. Now, as far as imaging goes, the important part is to detect a urologic malignancy, which is essential. That's often the primary goal of the imaging. But detection of alternative etiologies is desired as well, such as calculi. Traditionally, hematuria was evaluated with intravenous pyelography or retrograde ureterography and pyelography, but we have improved technology nowadays. So ultrasound can be used in some instances to evaluate adult hematuria, but is not the modality of first choice typically. There's no radiation exposure. It's very fast. Ultrasound is very good for evaluating for hydronephrosis, as well as looking for bladder wall thickening or clots if the patient has, again, presents with clots and the suspicion of macroscopic hematuria. And perhaps they've had some recent instrumentation or Foley catheter placement. Ultrasound can be obtained to look within the bladder. Ultrasound is also good at renal cyst characterization, perhaps an equivocal cyst seen on a CT that's very hyperdense, and we've raised the question about it being solid or cystic. Ultrasound can help. However, ultrasound is a limited assessment of the ureters. It's also insensitive for detection of stones, and it's also insensitive for small solid renal lesions. So overall, it's a limited evaluation in the broad sense for workup of hematuria. I managed to go backwards again. So here's an ultrasound of the bladder, which demonstrates an eccentric filling defect. Along the left aspect of the bladder indicated by the arrow. Now when we change position, this is a nice thing about ultrasound, you can have the patient change position during the examination. This area did not layer, it stayed fixed. It also had some blood flow in some of the other images obtained, and this was compatible with a transitional cell carcinoma on the not a problem. Would it be easier if I sat there? I'm just going to sit down unless anybody minds. I'll just forward it with the arrows. How about that? Not a problem. Okay. So now working up hematuria with MRI, the benefits are that there's no radiation exposure. Also, if the patient has an iodine allergy, you can use MRI without worries about exacerbating that allergy. It's very sensitive for renal lesion detection. It's also very good for characterization of complex and complicated cysts. However, MRI is insensitive for detection of stones and calcifications. It's quite motion sensitive and has a lower overall spatial resolution. And there's mixed results for MR urography. So you might get good characterization of renal cysts and solid lesions, but your overall evaluation of the urinary tracts and bladder can be somewhat limited. Here's an MRI image which demonstrates a normal right kidney, but the left kidney is largely replaced by this large heterogeneous mass. Additionally, the MRI demonstrates that there's renal vein invasion, which is a very typical pattern for a renal cell carcinoma with renal vein invasion. Here was a CT obtained for other reasons, which revealed a cyst in the right kidney. And you can see dependently within the cyst, there's at least some mural calcifications. Now at that point, it's considered a minimally complicated cyst, and you could either do an MRI or a CT with contrast protocoled for evaluation of that cyst to further evaluate. They chose to do an MR at this time, which revealed no enhancing components, and that's very important. You may hear us throw out the terms Bosniak-type cysts, and we gave it a Bosniak 2. It was a minimally complex cyst, no solid enhancing nodule or solid component, which would make it a Bosniak 3 or 4, which typically needs a urologic consultation and perhaps ablation or partial nephrectomies or a full nephrectomy. Here's MRI of the bladder. I think this is quite obvious, a big lobulated mass within the bladder, delineated against a very high signal urine as well as a Foley catheter in the bladder. And this, again, was a transitional cell carcinoma. So CT has become our standard examination for workup of hematuria, specifically the CT urogram. CT is excellent for detection of nephrolithiasis and calcifications. It's very good at characterization of complex and complicated cysts. It's fast and less motion sensitive than MRI. And very importantly, 95% sensitivity in detecting upper tract malignancies, which can be limited with MR and ultrasound. The downside of CT is it involves radiation exposure, and it's also insensitive for the detection of flat bladder lesions. You can see how somebody could miss those. But in general, for a full workup of hematuria, we do this in conjunction with cystoscopy, as well as performed by urology, as well as urine cytology. So the basic protocol for a full CT urogram involves axial unenhanced images as well as axial nephrographic post-contrast images and delayed excretory phase images. We then produce some coronal reformations of the delayed phase images to form the complete CT urogram. And I'm going to show you that here. You have the unenhanced images as well as the nephrographic phase images. You can see there's a lot of enhancement within the kidneys. And then finally, we have excretory phase images with the contrast has moved into the collecting systems. So you get an evaluation of the renal parenchyma and then the collecting systems. Another protocol CT that we'll often do for hematuria, specifically when there is flank pain, is a renal stone protocol. And I'm sure a lot of people here have ordered renal stone protocol CTs. Now, importantly, we do those without any contrast. Okay, so that does limit our sensitivity for some of the solid abdominal viscera pathology. But again, this is a tailored examination based on somebody's clinical opinion. And we do things that are very unique to this protocol, such as putting the patient prone. Okay? And the reason we do that is so that any dependent calculus within the bladder would fall away from the UVJ and not be confused with the UVJ calculus. So in this particular setting, this patient had unilateral left renal enlargement with ureterectasis. Down lower in the pelvis, you can see that they still have dilation of that left ureter, still dilated all the way down to the level of a calculus. And again, if there was something dependent in the bladder that just happened to fall in that position on a supine CT, that could be confusing. So you can see how the clinical indications and your guys' clinical opinion can drive us to do a more appropriate test. This is UVJ calculus. Here is CT urogram during the nephrographic phase reveals a big, large, heterogeneous mass in the left kidney. There is some necrosis. This is, again, a renal cell carcinoma, the CT correlate for that previously seen MRI mass. Now, again, here's a case where our conclusions are based on your clinical opinion. This is a patient who had pyelonephritis. They came back in and had a CT and had this small fluid density mass in the left kidney. In itself is quite nonspecific. Is it a cyst? Other etiologies as well. But in the case of having prior pyelonephritis, the suspicion for a renal abscess was raised. And on percutaneous drainage, this turned out to be a renal abscess. Now, there are some congenital causes of adult hematuria, including this particular entity, which is polycystic liver and kidney disease. Here's another case where there's, again, some pancreatic cysts as well as some renal cysts. But the problem here is that you have bilateral solid renal masses, which are always suspicious. This person ended up having von Hippel-Lindau syndrome with pancreatic and renal cysts with renal cell carcinomas bilaterally. Now here I think is one of the true powers of the CT urogram, which is the excretory phase, if done appropriately. On the pre-contrast images, there's a slightly hyperdense mass in the bladder. Now if this was smaller, I think this could easily be missed, okay? But during the excretory phase, you can see that the excreted contrast will outline the margin of that mass. And then we do, again, those coronal reformatted images of the excretory phase. And you can see that that dependent excreted contrast outlines that lobulated mass, in this case, a transitional cell carcinoma. Here's a slightly more subtle case, not necessarily the lesion within the left renal pelvis. I think we would pick that up quite well. But also within the bladder, there's a tiny little mass, which is outlined by that excreted contrast. And this is in the same person. And that's synchronous lesions in the setting of transitional cell carcinoma, which can happen in about 35% of the upper tract TCCs. So it's something we certainly look for, multifocal disease. So let's move on to the first imaging boomerang that I call it, the adrenal incidentaloma. I'm sure that a lot of you have read in the reports that incidental node is made of an adrenal mass. It's in quite a bit of studies. In fact, up to 4.4% in one study. The two main questions raised are, first of all, is it malignant? And second, is it functionally active? Differential diagnosis is quite broad, including some benign as well as malignant etiologies. In the picture here is a case of an incidental adrenal mass. You can see that inside that adrenal mass there is fat density. This CT was acquired for reasons unrelated to this. And that fat density is the same as the perinephric fat. Fat density containing adrenal mass is, by definition, a myelolipoma. This was benign. No further workup was needed. But often, it's not this simple. So we have some imaging modalities which will help us sort out the incidental adrenal mass. We can use MRI, specifically the in and opposed phase sequences, to evaluate for intracytoplasmic lipid, as it's called. And that's seen in lipid-rich benign adenomas in higher quantities. Furthermore, we can use an adrenal protocol CT. Now that involves a pre-contrast image as well as portal venous and 15-minute delayed images. And this evaluates for two different characteristics of adenomas. First of all, the non-contrast images can look for a very low-density adrenal mass. If it's less than 10 Hounsfield units, it's got intracytoplasmic fat, it's considered a benign adenoma. And our workup would stop. That would be checked by a radiologist and would be done. Now, if it's of a higher density, we'll move on to portal venous and 15-minute delayed to evaluate for an absolute washout. And if it's greater than 60%, then it's characteristic of an adenoma as well. And in some problem-solving cases, PET has been used in some institutions to evaluate for metabolic activity. In itself, it is not a reimbursable indication at this time. It would have to go through NOPR, the National Oncologic PET Registry, to be approved at this time. But with PET imaging performed for other reasons, say workup of lung cancer or breast cancer, we sometimes see hypermetabolic nodules, which are worrisome then for metastatic disease. So here's an MRI, adrenal protocol. The in and opposed phase T1 weighted images, which demonstrate a significant signal loss, and this was a benign adenoma. Here's a case using the adrenal protocol CT, where on the pre-contrast we're at 38 Hounsfield units. It's not less than 10. We're going to move on. We're going to look at the portal venous phase, 70 Hounsfield units, as well as the washout, 45. The washout here was 78%. It's greater than 60%. It was considered an adenoma. Here's a more complicated case where they first got the MRI, and we did not have significant signal loss. And then the washout CT also demonstrated insignificant washout. This mass is indeterminate. And on our algorithm here, we move on to following this or biopsying this lesion. So let's move on to right upper quadrant pain. Some causes of right upper quadrant pain, as you know, include acute cholecystitis, which is very common, ascending cholangitis, pancreatitis, biliary colic, hepatic abscesses, and a wide number of other things. We use a lot of the clinical clues for guidance, as you do as clinicians as well. If it's got an elevated lipase, we're going to think it's pancreatitis. History of gallstones raises cholecystitis very high on the list. Maybe postprandial pain for biliary colic. And even sometimes with a cough and a white count, does the patient have a lower lobe pneumonia, particularly in kids where intrathoracic pathology can be mimickers of abdominal disease. Our first choice modality is ultrasound to evaluate right upper quadrant pain. Very highly sensitive for detecting gallstones and biliary dilation. It's safe. It's easy to get to. Computed tomography CT is less sensitive for the detection of gallstones, which is something we're always looking for. It involves a radiation dose, but it may be very complementary to ultrasound in complex cases. An MRI or MRCP can complement ultrasound in complex cases. It involves no radiation, and it should be known that MRCP doesn't require gadolinium contrast, which is important to know in the setting of and worries for nephrogenic systemic fibrosis with contrast administration. An MRCP does not require contrast. Here is a patient with right upper quadrant pain, had an MRCP performed. There's a normal gallbladder as well as a normal pancreatic duct, but there's this irregular beading of the intrahepatic bile ducts with areas of narrowing as well as dilation. And this is a person with primary sclerosing cholangitis. Now, one of the diagnoses we're definitely looking for is acute cholecystitis. And this is, I would say that the vast number of right upper quadrant ultrasounds are ordered to rule this out. It occurs in up to a third of patients with gallstones, and about 95% are due to calculus obstruction of the gallbladder neck or the cystic duct. So again, ultrasound is our first modality of choice, and in the mid-'80s, a study showed that the combination of cholecystolithiasis and a positive sonographic Murphy sign had a 92% positive predictive value for acute cholecystitis. Additional findings that we'll look for on the ultrasound, and you may hear us comment on a report, is a distended gallbladder, perhaps gallbladder wall thickening or hyperemia, or a pericholecystic fluid. This is a patient who has a shadowing gallstone, as well as had a positive sonographic Murphy sign. This was acute cholecystitis. There was worried about that this may represent a complex case with complications, so an MRI was obtained. Didn't show any complex case or complications, but it does show the MR correlate to the ultrasound findings, which was this low signal gallstone, as well as this pericholecystic inflammatory change. Here's another ultrasound showing acute cholecystitis. Here we have wall thickening of the gallbladder, as well as hyperemia of the wall. Now, the radiologist's role in this whole situation is not only identifying the acute cholecystitis, but again, identifying complications which would make temporizing the situation ill-advised or potentially result in an open cholecystectomy or perhaps a percutaneous drain. Some of these complications include gallbladder perforation, emphysematous cholecystitis, and a cholecystoenteric fistula. Here's a patient who had acute cholecystitis, had a persistent fever, a lot of right upper quadrant pain. You can see that there's a small disruption in the gallbladder wall, as well as this fluid and low density within the adjacent liver parenchyma. This was a gallbladder perforation with abscess. Here's another case, an ultrasound which was obtained for right upper quadrant pain. And you can see these small areas of linear echogenicity emanating from what was the gallbladder wall. Now, we may see these in situations where there's what we call a wall echo shadow complex, a lot of shadowing that we see from the gallbladder wall that just comes from a gallbladder that's filled with stones. But not in this case. This isn't a true wall echo shadow complex. This raised the concern of a particular diagnosis, and CT was obtained. you can see that the entire gallbladder wall is outlined with this gas attenuation, which is similar to the non-dependent gas in the stomach. This is a diagnosis of emphysematous cholecystitis, which is typically seen in very sick diabetic patients. Here's another case. A patient had right upper quadrant pain. They certainly have cholelithiasis, but they didn't have any evidence for cholecystitis. What was picked up at the time by the radiologist was that there was some subtle hypoechoic area within the adjacent liver parenchyma. Again, as a problem-solving modality, a next step, CT was obtained, which again reveals the cholelithiasis, but in addition shows that there is low density extending into the adjacent liver. This time it was not an abscess. Instead, this elderly woman had a gallbladder carcinoma. The next case on a right upper quadrant ultrasound was this polypoid mass within the gallbladder. It was non-dependent. It was also non-shadowing. It doesn't look like a gallstone. The considerations at the time, could this represent a big polyp, perhaps some adherent sludge? It was at that time worked up further with MRI, which showed that it was enhancing. And at that time it was thought, well, this is probably a large polyp. Either way, with this size, greater than a centimeter, surgical removal of the gallbladder is indicated. But on pathology, it turned out to be a metastasis to the gallbladder from lung cancer. Not common, but the point is it would have been removed anyway, but the MR helped to further evaluate whether or not it was enhancing and truly sludge. This is a case, and we see this quite often. There's the pancreas, which shows a lot of adjacent peripancreatic fat stranding. This is acute pancreatitis. Now, CT is not the first choice of diagnosing pancreatitis. That's done clinically, elevated amylases and lipases. But the strength of a CT or an MRI is to evaluate for complications like acute fluid collections, pseudocysts, abscesses. As in this case, this is a case where the patient had subacute pancreatitis. You can see that there's a lesser sac pseudocyst that formed, as well as this area of non-enhancement within the mid-pancreas, which was pancreatic necrosis. So we have both pancreatic necrosis and a pseudocyst. Follow-up examination showed evolution of these changes as that area of necrosis also became a pseudocyst, and there was enlargement of that lesser sac pseudocyst as well. Now, choledocholithiasis, or stones within the biliary tree, may cause pain and possibly jaundice. It can also result in obstruction and ascending cholangitis, which will present with fever. Ultrasound itself is 70 to 75% sensitive for common bile duct stones. And if positive, then ERCP is typically recommended for definitive management. But if the ultrasound is negative, then the next step is often an MRCP. MRCP is 95% sensitive and 100% specific. Here's an MRCP, again done without contrast, which demonstrates choledocholithiasis. Other etiologies for biliary ductal dilation include strictures, pancreatic head masses, and biliary neoplasms. Here's an ultrasound done for right upper quadrant pain, which showed ductal dilation. Those ducts are way too big. There was also hypoechoic pancreatic head mass with shadowing. Very suspicious for neoplasm at that time. So what's the next step when something like this is seen? Well, the next step is a pancreatic protocol, MRI or CT, for purposes of evaluating the extent of disease as well as staging at that time. We can see that there's intrahepatic ductal dilation. This is the same case, as well as dilation of the common bile duct and the pancreatic ducts. And this is all leading to a pancreatic head mass, which was quite extensive. This is a pancreatic adenocarcinoma. At the time of this examination, using this tailored CT, we were able to stage it. We looked for local regional nodal metastatic disease. There's also a chest, which was done with it, a chest, abdomen, and pelvis. And this particular case had greater than 180-degree abutment to the superior mesenteric artery on other images. It was non-resectable. Another case of right upper quadrant pain, the ultrasound showed some ductal dilation, so they got an MRI to further evaluate. This showed some high T2 signal as well as corresponding enhancement along the biliary ducts, which itself is nonspecific. Could this be infection, inflammation, neoplasm? But the MRCP that was done as well showed that there was a central area of stenosis at the hepatic hilum, very suspicious for the neoplasm, which on brushings turned out to be cholangiocarcinoma. Now, there's a brief tangent here. When we do examinations for right upper quadrant pain, we often find incidental lesions. And I'd just like to make my plug for MRI to further evaluate those lesions seen. It's often the best test if the patient is MRI compatible, no pacemaker, et cetera. This is a case where an incidental lesion was seen on ultrasound. It was characterized as MRI, having a small central scar as a benign focal nodular hyperplasia. Here's another case, an incidental lesion that we often see. A serial tailored MRI images with contrast demonstrate progressive peripheral nodular enhancement, as seen here. There's another lesion smaller within the right hepatic lobe, which also demonstrated progressive enhancement. And these were hemangiomas, benign, the workup's over. This is a case of a patient who had hepatitis B, long-standing cirrhosis, which was known. She had a bump in her alpha-fetoprotein, which was being monitored by her clinicians, so an MRI was obtained. She had multiple regenerative and dysplastic nodules, but a couple of these masses were enhancing with high T2 signal and rapid washout. And unfortunately, this was a multifocal hepatocellular carcinoma. So next, we're going to move on to lower abdominal and pelvic pain. Now, like anything, the anatomy is going to predict the pathology we're looking at. And in the lower abdomen and pelvis, we are dealing with large and small bowel, mesentery, the urinary tract, uterus and ovaries in females, the scrotum and scrotal contents in males, as well as the abdominal and pelvic wall. Now, CT in the acute setting is our first choice test, a tailored CT. And this is often the source which what we're looking for in right lower quadrant pain. We have an inflamed tubular structure in the right lower quadrant. There's a small appendiculus, and this was acute appendicitis. So not only do we use the CT for diagnosis of the acute appendicitis, but also looking for complications. If it's ruptured and has an abscess, they may require us to put a percutaneous drain in. Here's another case of abdominal pain. We're pretty good, despite the underdistension, at looking for gross colonic pathology. In this particular case, there was pancolonic wall thickening in the setting of a hospitalized patient with Clostridium difficile colitis, which is also quite common. Yet another common source of abdominal pain that we see is right here. There's segmental wall thickening of the colon, as well as a small inflamed diverticulum there. This is diverticulitis. And similar to appendicitis, we use the CT not only for diagnosis, but looking for complications that may require drainage or may tell the clinician that antibiotics in this situation are not going to be enough. Here's another case of colonic wall thickening with some adjacent stranding, and somebody may say this could be a colitis, infectious, inflammatory. I don't see any diverticuli here. This actually turned out, after being treated, the person was scoped, and this turned out to be a colon cancer, which was perforated. And that's why sometimes in our reports, you may read that when the acute exacerbation is over, we'd recommend endoscopy if the patient hasn't recently had it. And because I've had more, in my limited time being a radiologist, more than a handful of times where it turns out to be an occult perforated colon cancer, especially when we don't see any adjacent diverticuli or a causative etiology. CT is excellent for looking at small bowel, particularly small bowel obstruction, as is this case. We can look for the transition point and delineate a small bowel obstruction from an ileus. In this particular case, it was a left inguinal hernia, which was resulting in the obstruction. Here's another case of obstruction, this time caused by a ventral hernia. So not only is the CT good for looking at the bowel, but you can see that it's pretty good at looking for the abdominal wall, hernias and such. This is another case of abdominal wall pathology. The patient had acute lower abdominal pain. The CT was actually obtained to look for acute appendicitis. They were on Coumadin, and this turns out to be a rectus sheath hematoma, quite a large one, with an area of acute extravasation of contrast delineated by the yellow arrow. Similarly, CT is very good looking at the omentum and mesentery, which is often a neglected, a forgotten source of potential abdominal pathology and pain. Here's one such diagnosis that we see quite a bit, actually. It's a small little fatty area with adjacent inflammatory changes. This is a typical location just anterior to the sigmoid colon. This is epiploic appendicitis. This is typically treated with NSAIDs. It doesn't require any other further treatment. A larger area of fat with surrounding inflammation, although in this time in the left lower quadrant is more common in the right lower quadrant, but this is an omental infarct in a patient who had recently had surgery. Now, the pregnant patient with right lower quadrant pain can present some problems. And I know we get quite a few phone calls, typically in the hospital setting, about what to do. Typically, our first step, if there's concern for acute appendicitis, is to do graded compression ultrasound, okay? Because we're looking not to administer radiation to these patients, obviously. So if we can see the inflamed appendix, we call it acute appendicitis, and we move on. If we do not see the appendix, it doesn't mean it's normal, okay? There's limitations to ultrasound, certainly. And often we'll do this examination, which is a tailored MRI. The tailored MRI is done without gadolinium contrast because of fears of it crossing the placental barrier. It's a relatively rapid test. The radiologist will check the study and also do additional sequences if necessary. So here we can see low in the pelvis that there is the gravid uterus. Okay? We'll also see this tubular structure in the right lower quadrant. Now on other images in the axial plane, this was confirmed to be inflamed, enlarged for the size of an appendix. It was greater than 6 millimeters. It also had some adjacent subtle inflammatory changes. And this indeed was acute appendicitis in a pregnant lady. Now etiologies for pelvic pain in the female are pretty broad, anything from endometriosis all the way to ovarian vein thrombosis, and we've certainly seen all of these in our practice. Typically, ultrasound is the first step, as it is safe and can be performed in the acute setting pretty much anywhere. MRI is appropriate for further characterization, such as an adnexal mass, trying to tell whether it's a solid mass, perhaps a hemorrhagic cyst that didn't resolve, or an endometrioma. I'm not going to get into too much detail because I understand Dr. Wellman talked a lot about this earlier. So in brief, we're going to look at a few cases. This is the left ovary in a patient with right pelvic pain, which shows a normal left ovary, normal blood flow in that left ovary, seen by ultrasound. But the right ovary, I think even to the naked eye, looks large. It's got a big cyst in it, which actually served as a lead point, in this case, of right ovarian torsion. Now here's the use of MRI in a more complex case. This patient had bilateral adnexal masses. Some of these were felt to be intraovarian, even within a very posteriorly located right ovary. But on a 6-week follow-up, which was appropriate to evaluate whether these were hemorrhagic cysts in this premenopausal female, they did not resolve. In fact, a subsequent follow-up was obtained, and they also did not resolve. So in that case, MRI is indicated to evaluate could this be some benign or malignant neoplasm, but there was suspicion that it was indeed this entity of endometriosis. As you can see from the T1 to T2 weighted images, it's hyper intense on both, but there's a little shading on the T2. It's a little bit darker, and this was endometriosis. Now, this is not to say that CT cannot diagnose pelvic pathology. It's just not as good at characterizing it, okay? This is a young woman who came into the office. She had acute right lower quadrant pain. Appropriately, CT was ordered, okay, given with IV and oral contrast. However, this woman has a lot of hemoperitoneum, this high-density free fluid within the abdomen. Women can have a small amount of pelvic fluid, but this is way too much. It's up by the liver, you can see, and the spleen as well. Now, down in the pelvis, she's got this small peripherally hyperdense and centrally low-density mass within the right adnexa. Now, the suspicion based on this CT with our experience was this represented a hemorrhagic cyst. And as you can see, there can be a lot of blood in the belly from a ruptured hemorrhagic cyst. Now, the CT didn't really characterize this well. It was just the experience of a young woman with this type of morphology is typical for a hemorrhagic cyst. It was later characterized on a follow-up ultrasound. But again, this is a ruptured ovarian cyst with massive hemoperitoneum. Now, in the male with scrotal pain, ultrasound is your modality. And with acute pain, this time left-sided, the color Doppler images showed no flow in the left testis. Right testis showed flow with a normal waveform. This is left testicular torsion. Another case of scrotal pain, this time on the right side, showed a very hyperemic, with all that color in it, epididymis and the testis. Contralateral side, normal blood flow. So this time you're talking about too much blood flow. Again, ultrasound very powerful for detecting and characterizing how much blood flow we have in structures. This is right epididymitis orchitis. This is a somewhat unusual case of a young man who had trauma to the scrotum, and he came in. The ultrasound images are obviously abnormal. There's this very hypoechoic area within the testis on the side of pain. Now, it was thought that could this be hematoma, but the color flow by the ultrasound showed that there was a little bit of color in there. Could that be just maybe some parenchyma that still had flow in it, or was it something else? Well, the suspicion that maybe it is something else. And so, as a problem solver and further evaluation, CT was ordered. Not CT of the scrotum, but instead CT of the abdomen to evaluate for the potential of adenopathy. And the reason why this was done is that we know that testicular neoplasms, particularly seminomas, often will metastasize into the retroperitoneal nodes. And that was the case. Just happened to pick it up when he had trauma. Seminoma with retroperitoneal adenopathy. So now we're going to briefly move it into the chest, talk about a couple indications. This isn't going to take very much time. I'd like to discuss a bit about masses and nodules we see on chest x-rays being worked up with CT. CT is typically what we do to work up these masses and nodules. Just to show you some pictures, here is a chest x-ray which was done. Shows this contour abnormality along the mediastinum, quite abnormal. Now we have a couple options. Again, a lot of this is about how do we tailor the exam to solve problems. Okay? Here, when you have central masses, we like to give contrast, and that's to delineate masses and hilar structures from those vessels and other things which can cause some confusion. So in this particular case, CT with contrast was ordered. I don't think anybody's going to miss this particular mass even without contrast, but this was a large central mediastinal mass, which turned out to be a small cell lung cancer. Here's another case of a patient who had recurrent pyogenic bacterial brain abscesses, and he also had this pulmonary nodule. CT was ordered with contrast. These are the bone windows, so you're not going to see the contrast well, to further evaluate this pulmonary nodule. It turned out to have a feeding artery as well as a draining vein. This was a pulmonary AVM, which was causing right to left shunts, and this person was seeding his brain with bacteria. Now we're going to move on to the next imaging boomerang, which is the solitary pulmonary nodule. Now, as CT use worldwide has increased, the number of pulmonary nodules less than a centimeter has also increased. But malignant lesions account for only 60 to 80% of these nodules, depending on which study you read. There's also considerable overlap between the benign and malignant nodules in terms of morphology. Very rarely can we just look at a nodule and say that's definitely benign. Okay, sometimes we can, but it's not that common unless it's diffusely calcified. Various strategies have been used to further evaluate the solitary pulmonary nodule. People have tried growth rate assessment over serial examinations, contrast-enhanced CTs, and PET. Now, the differential is quite broad, anything from malignant tumors like lung and primary carcinoid to metastases to benign things like granulomas from histoplasmosis or TB. So what the attempt that's been made is to try to standardize what are our recommendations when we see these pulmonary nodules that we're picking up more often. And the Fleischner Society in Radiology published their results, and these are recommendations for follow-up and management of nodules smaller than 8 millimeters, which are incidentally detected on non-screening CT. And I can tell you, our practice tries to follow these. And it's important because what it does is it provides a nice standard framework so that we're all on the same page. Okay, and then therefore you're on the same page about what we're doing with this pulmonary nodule. And this is segmented into low-risk or high-risk patients. And you may ask, well, what's a high-risk patient? Well, a high-risk patient would be defined as somebody who's a smoker or has a history of a primary malignancy. And typically their follow-up intervals are going to be shorter. But the goal here is to establish 2 years of stability and therefore presumed benignity. Now, in some institutions, a thin-slice contrast-enhanced CT has been used, and using a threshold of 15 Hounsfield units, they achieve a sensitivity of 98% and a specificity of 58% for malignancy. So they look at the contrast enhancement of these pulmonary nodules. But realistically, this is not taken off. It's not used in clinical practice. It's cumbersome. It's difficult to reproduce. So it really hasn't been widespread. Now, on the other hand, FDG PET has a sensitivity of 88 to 96% and a specificity of up to 90% for the malignancy, also depending on which study you read. Here's an example. Fused images of a solitary pulmonary nodule which was detected shows that it's markedly hypermetabolic, and this is lung cancer. Now, things to know about PET imaging, and again, Dr. Haugen may be getting into this in a little bit more detail. The spatial resolution of FDG PET is about 8 millimeters. So you can have false positives as well, and that can be seen in the setting of tuberculosis, histoplasmosis, or rheumatoid nodules. I had one the other day that was clearly histoplasmosis, which was causing these nodules to be very hypermetabolic. But they had a constellation of findings that pushed me in that direction as well, some of their calcified mediastinal adenopathy. False negatives can include carcinoids and bronchoalveolar carcinomas, which have a baseline low metabolic activity, as well as malignant solitary pulmonary nodules, which are less than 1 centimeter in size. Now, one study did show that the false negatives are seen in only 3% of stage T1 cancers greater than 5 millimeters, which is a very important finding. Additionally, on resection, those tumors tended to be more indolent. So in the workup of a solitary pulmonary nodule, which is greater than 8 millimeters, PET can be a very powerful tool. Next, briefly, I want to talk about persistent chest X-ray opacities. These are opacities where you have the first chest X-ray that was ordered for maybe cough, fever, and you found something. And our recommendation probably said, recommend short-term follow-up chest radiographs to resolution. Okay, and I'm going to show you why we do that, and then also the appropriate follow-up. Here's a case. The person had serial chest radiographs which showed this heterogeneous bilateral opacity. Initially, it was thought this could represent atypical infection. They had a course of antibiotics appropriately. They got a follow-up. It didn't change. In that case, CT is a very appropriate examination to further characterize this opacity. And the CT obtained in this case showed these areas of perilymphatic nodules as well as these scattered reticular opacities. Other images also showed that the patient had mediastinal adenopathy. This is very typical for sarcoid, and obviously the antibiotics were not going to fix that. Now, the therapy initially was based on clinical indications of cough and fever, and it was appropriate, but obviously the CT now has changed management for this patient. Here's another case. It looks very similar. I mean, these are bilateral, diffuse, heterogeneous opacities. You're not going to make too much out of this, okay? They had antibiotics. It didn't go away. The second radiograph looked the same as the first. This person also got a CT, but look at how dramatically different this looks. This is a different entity entirely. This is these diffuse interlobular septal thickening with little areas of ground glass. It's kind of like a honeycomb-like appearance. It's often called crazy paving, actually, in the radiology literature. This is indicative of pulmonary alveolar proteinosis. This totally changes the therapy of this patient. You're talking now about steroid treatment, bronchoalveolar lavage, and different types of treatment. And in this case, this person had a right upper lobe collapse. Now, sometimes we'll see collapse atelectasis, which will just resolve. But in this case, it didn't resolve. So always the concern in the back of our minds is, could there be something centrally obstructing a bronchus or causing mass effect? A contrast-enhanced CT, again, contrast-enhanced because we're looking for something central. We want to delineate this from the vessels, was obtained. Shows that the person has that right upper lobe collapse, as well as, very importantly, a central mass, which turned out to be a non-small cell lung cancer, causing that collapse. Now we'll shift gears a bit and talk a little bit about shortness of breath and chest pain. Now often, there's some diagnoses which don't even require imaging, but there's some that do, and often the first step is a chest x-ray. But sometimes the chest x-ray is negative. In fact, oftentimes it's negative or non-contributory, and the clinician, appropriately so, wants to move on to a CT exam. Well, you should know that we really do use the clinical information provided to us to tailor that CT examination. Okay? If you're worried about pulmonary embolism, the CT is tailored to look at pulmonary embolism. It's timed so that the pulmonary arteries have more enhancement so that we can accurately detect that. As in this case, where you have a central filling defect within the pulmonary artery on the right, which was a large pulmonary embolus. Now, let's say that there's more of a worry for dissection. Well, somebody may say, well, that's not important necessarily for the radiologist to know, but it is. And the reason it is because we may throw in this type of a protocol. And this is a dissection protocol, and this is, again, tailored for the patient, for the provided indication. We do, in those cases, non-contrast imaging through the chest, specifically to look for this entity, which, as you can see, is this crescentric high density within the wall of both the ascending and descending aorta. Okay? Now, what everyone thinks of as the dissection protocol is the post-contrast imaging, where we're looking for the dissection flap and all that. This person had no dissection flap, but they did have that intramural density, which was intramural hematoma. Now, that's very significant because those are treated similarly to a dissection. And we've seen that. I think in this last month, I've seen at least 3 cases of this. So this is a type A involving the ascending and descending. This is an aortic intramural hematoma. And you can see that the information that you provide us can help tailor a protocol that's more appropriate to the patient. So with that, you can see there's multiple modalities which are available to evaluate hematuria, right upper quadrant pain, and lower abdominal and pelvic pain. The clinical data that you provide us is essential for choosing the appropriate imaging test or tailoring a protocol. It's a win-win situation. And adrenal incidentalomas and solitary pulmonary nodules often require additional dedicated imaging to solve the problem. Thank you for your attention.
We have 2 minutes for questions if you have anything. Otherwise, you can wait. You did it. We can wait for the, so if questions arise, we have a question-answer period right after Dr. Haugen speaks. But does anybody have a quick question they'd like to ask Dr. Schulz? Yes.
When you get somebody with hematuria, you found him at the old age?
Well, so I'm just going to repeat the question, which is, if the patient has hematuria, what is the CT protocol that should be ordered? Now, there is some debate over this. If the patient is a very young patient and has flank pain with hematuria, I would think that a renal stone protocol would be very appropriate. Patients who don't, I get more worried when patients don't have pain and have hematuria, especially, older than 40 or so. I think a CT urogram is very appropriate because, again, you're not really sacrificing anything. You're still getting that non-contrast look to look for stones. Okay? And sometimes people will say, well, they just had vigorous exercise or something. You got to be careful about banking on all these things that may cause hematuria. Perhaps even sometimes you'll say, well, I'm going to take one sample. It's one time of hematuria. And sometimes urologists will not order a workup imaging at that time. But if they have another sample and it's hematuria without flank pain, I would go with the CT urogram. Okay?